Hey, good morning. My name's Guru. I have the pleasure of talking to you about the future of our workforce at 8:30 in the morning. I know it's a bit of a dense topic. A lot of people have strong opinions, but my hope is to kind of go through some of the data that's been published, talk through some potential conjectures of where the future of our workforce is going, and then definitely want to leave some time at the end to hear your thoughts on what you've heard, and maybe debate a little on what we think is going to happen next for our specialty. So like I said, we'll start going through the ASAP workforce study. We'll also talk through ASAP's new task force, looking at new practice models, and then kind of end with a few future projections about the workforce. So just by a rate, like raising your hand, how many people are familiar with ASAP's workforce study? Okay. And how many people have actually read the study? Nice. Okay. How many people have gone to an event or lecture kind of similar to this, talking about either the future of our workforce or this study or future of medicine in general? Okay, nice. So that kind of gives me an idea of where to start. This workforce study was commissioned in 2018, published in 2021. A lot of people don't realize that ASAP has actually done this multiple times before. They published workforce studies in 97, 99, 2007. There's also been many other research groups that have projected what the EM workforce is going to look like. Previously, these studies were really focused on how our specialty could grow. It was when we were first starting. So they really wanted to focus on how to make sure that emergency care was being provided by emergency medicine physicians. Most of these were surveys that were sent to medical directors or nurse managers to assess the demographics of who was practicing in EDs, but really didn't look at supply and demand. And that's what was different about this study. So this study was the first of its kind to really try to analyze what the supply of emergency medicine providers would look like over the next 10 years, and then compare it to what the demand for our services would be, and then try to determine if there was going to be a supply-demand mismatch. A lot of this was due to concerns in 2018 about the growth of our specialty, especially in the amount of growth within our graduate medical education, as well as efforts in society to decrease ED utilization through value-based care programs. So as with any study, what were the methods, what was the design, how did they get the numbers that they got? So they kind of strategically went through the different factors of supply and demand for emergency medicine services. They looked at how many physicians we currently have by looking at AMA data, as well as how many physicians were billing for emergency medicine services, to understand who was billing as an EM physician versus non-EM trained physician versus NPs and PAs who were billing under their own licenses. They also looked at what the inflow of emergency medicine providers would look like over the next 10 years, specifically looking at how many residents were going to be trained in EM, but also looking at the inflow of NPs and PAs into our specialty. They also tried to calculate how many of our physicians were leaving the workforce and how many non-EM physicians were leaving the workforce, and they were actually leaving at a much higher rate. And then lastly, they tried to figure out how many visits were being seen by NPs and PAs primarily, and then also tried to get a number for how productive our workforce was. These were the numbers they came up with in order to determine what the supply for EM services would be. And then the last piece was looking at how much the demand for services would grow. They used a data set, the NEDS data set, which is the National Emergency Department sample. And that kind of stratifies ED use by age to project out, as we have an aging population, how much our society will need EM services. They projected about an 11.2% growth rate over the next 10 years, and that factors in about a 2% decrease in ED utilization through value-based programs and things like that. So going through all these calculations, they put it into a supply-demand formula and came up with these numbers, which have been published everywhere and kind of caused alarm throughout our specialty. And they basically projected that the supply of EM physicians in 2030 would be around 59,000, while the demand for EM physicians would be around 51,000, and that was going to leave a supply-demand mismatch of around 7,800 EM physicians. Since this study was published, though, we've had revisions in that data. This study was done in 2018. Since then, we've had huge societal changes, specifically the COVID pandemic. And we've actually seen that the attrition rate is a lot higher, closer to 5%. And additionally, last year, we saw that many of our GME spots went unfilled. So while they projected for a 2% growth in GME, it's most likely that that will be 0% or possibly negative, at least over the next few years. So the overarching question when we kind of look at this data is, what do I do? What do I, as an EM resident or a new EM attending, what does my specialty look like for the rest of my career? Am I going to have a job? Is it a job that I want, or is it one that I'm forced to take because there's no other option out there for me and I need to make ends meet? So I think what I'm hoping to talk through today is that the future isn't as bleak as it sounds. What it really looks like, based on the projections that they made, is that while the one that was published showed that there was going to be an oversupply, if you adjust the numbers slightly, including the more current 5% attrition rate, the non-growth in GME, as well as some other predictions, such as like the same number of NPs and PAs, like seeing primary visits, we'll actually still have an undersupply of EM physicians in 2030. So these projections are just a guess at what might happen. And now that we know that this is a potential future, the chances of this actually happening are slim to none. We're already doing things within our specialty to make sure that we prepare for the future. And one of those things is the New Practice Models Task Force. So ACEP convened this task force in 2022, and the goal was really looking at what it means to be an emergency medicine physician. What are the skills that we are trained in, and what is our expertise, and what do a lot of our physicians have interest in? And how do we figure out where that overlaps with what our society needs, what our healthcare system needs, and then determining what we're already doing to meet these needs and what are potential opportunities for our specialty going forward. So they specifically looked at all these roles, the traditional physician roles that we already fill, but also the new ones that we could potentially fill based on where our society is going, and did a SWOT analysis, SWOT being strengths, weaknesses, opportunities, and threats, and really tried to drive down into where ACEP and other EM organizations could focus their advocacy, research, training, and really prepare future residents and the specialty overall for changes that were going to come. So in terms of what already exists, this is a list of specialties we already practice. Many of us get trained in this during residency. A lot of people do fellowships in these specialties. And a lot of people later in their career may decide to go off and pursue careers in education, administration. People do legal case review or insurance utilization review, and many people do fellowships in geriatric medicine or global health or PAL care. And these opportunities will only continue to grow as there are more residents and more desire to go into these specialties. Now, the real question is what could exist. Some of these already exist. For example, proceduralists. This is in-hospital proceduralists, so running a line service or airway service within a hospital. Pain medicine or addiction medicine physicians. A lot of people in our specialty are starting to venture into this field. As space travel starts to increase, things like aerospace physician or cruise ship physician are going to be roles that EM physicians are going to be asked to fill. And there's also going to be other leadership opportunities in our society, for example, being international relationship liaisons or physician coaches, public speakers. These are all opportunities that are slowly being taken up by EM physicians, and we'll kind of talk through some people doing this work. So after going through this intense analysis, the recommendations from the task force were to focus on these 5 areas. The priority areas were home-based care services, mobile integrated health, psychiatry and behavioral health, rural EM, and telehealth and virtual care. So how many people are familiar with this graphic? It's a bit of a gotcha question. But this is actually from a debate between Scott Weingart and Simon Carley at the CODA conference. It was, I believe, in 2017. And the question was, is emergency medicine a failed paradigm? And at that point, when our specialty started, it was pitched to everyone that we were in the ER, we took care of sick patients. But as our specialty started to grow and we had time between our sick patients, we start to see people who were not that sick. And then slowly we start to see people who are not sick at all, but just didn't have access to care and needed our services. And then we also started to do some critical care, but as the ICU beds filled up upstairs, we started to hold on to those critically ill patients and manage them for much longer than maybe we were comfortable with. And talking through that, they debate whether EM as a specialty was a failed paradigm, which I strongly disagree with. I think emergency medicine has always changed and always will change in order to meet the needs of society at that time. And I think we are undergoing a bit of a paradigm shift in emergency medicine. And it really comes down to what is our core skill, and that is being available. And that's kind of our motto, that we are available 24/7, 365. We can do anything, anywhere, at any time. And that's really what it means to be an emergency medicine physician. And it's time, and basically the quote was that it's time to start thinking about emergency care rather than emergency departments. And how do we move the care that we're capable of providing and have become experts in within the ED and start doing it in other care settings in order to improve outcomes for our patients and also build a better career. Why do we want to do this? This is a graph from the AAMC of physicians practicing over the age of 55. EM is at the lowest end, towards the lower end of this graph, with only 36% of physicians 55 and older still practicing in their specialty. While our specialty is young, this is still, and that could contribute to some of this skew, it is still a concerning statistic. And we already know that EM is one of the fields that has the highest levels of burnout. We also have a high attrition rate. So how do we build our specialty to offer new care, new opportunities to provide care in order to allow for more fulfilling and longer careers? So one of the areas is that people have talked about a lot is telemedicine, as well as rural healthcare. Studies have shown that emergency medicine really has not penetrated rural communities, and often critical access hospitals don't have board certified emergency physicians providing care. This article was published in the Washington Post recently. It talks about how EM care is now being delivered in some of these critical access hospitals. It opens with an anecdote of a patient being brought in extremely altered and needing their airway controlled. And unfortunately, there's no EM provider in the hospital. They have a service where they contract with a telemedicine company where an EM physician is able to remotely view the entire resuscitation room through multiple cameras, has access to their EMR as well as their vitals and their cardiac monitoring system. And it talks through how an emergency medicine physician hundreds of miles away is able to walk a nurse and an APP with little experience through an intubation of a critically ill patient. For that patient, that meant they were able to live longer and eventually made it out of the hospital. But this is a novel area where EM is really trying to bridge care gaps that have existed in our society for quite some time, and is a way that we can use technology to advance the quality of care being given in rural communities. Another area that EM is really good at is transitions of care. Oftentimes we see patients who were recently admitted for a certain reason and then are discharged. They go home and then have something happen that causes them to bounce back to the hospital. And a lot of times, one of the things that we see often is, for example, CHF. So you have a CHF patient that's admitted for an exacerbation. They get treated, they get discharged, they go home. And then after a week or so, they kind of start to retain a little bit more fluid. And then they bounce back to the ED and end up getting readmitted. we're the ones that make that decision on whether a patient gets readmitted or not. So what if we started to make that decision a little bit sooner? And that's where programs like this, community paramedicine, really come in handy. So the crux of it is really that we make that decision in the end. If we can avoid that readmission or even that ED visit, we can prevent this patient from having another hospital stay, which puts them at risk for multiple other things, such as hospital-acquired infections, DVTs, et cetera. The way this program works is that you have paramedics going into a patient's home, usually a few days to a week after a recent admission. They're able to do a full health assessment in the house. That includes vitals, weights, a physical exam. They're able to tell you if their weight's going up and they're much higher than their dry weight, indicating that they're retaining fluid. They're able to listen to their lungs and see if their shortness of breath is getting worse. And then they're able to do a lot of things like make sure they picked up all the right prescriptions, making sure that they're taking the right doses of their medications, the common things that cause these patients to bounce back and end up getting readmitted. If they're starting to decompensate a bit, they're able to give IV Lasix in the home and follow up with them the next day. And all this is supervised remotely by an emergency medicine physician who's also able to watch all this, get the information, and make a decision on whether the patient actually needs to come back and get readmitted or can get treated in place with close follow-up and coordinate care with their other providers. This fills a gap that traditionally has already exists in our system. A lot of patients go home and due to factors out of their control and out of their provider's control, they miss appointments, they get the wrong prescription, or they forget to take a med that they were supposed to restart and they end up bouncing back. This is a nice way for them to kind of prevent that and avoid another admission. Lastly, to kind of close things out, wanted to talk about a few people who are doing things in our specialty that are extremely unique, but also show where our specialty could go in the future. I assume some people in the back might know a few of these people, but does anyone else? So starting from the top left is Dr. Jonay Caldoun. She was a county resident. She most recently went on to be the Deputy Commissioner for Health and Human Services in Michigan. She was the one that was running their COVID-19 response. After that, she just moved on to be the Vice President and Chief Diversity and Health Equity Officer for CVS Health. The person right next to her is Dr. Steven Stack. He is also an emergency medicine physician. He was the first EM physician who was elected to the board of the American Medical Association, and he was most recently the first EM physician to serve as president of the AMA. Next to him is Johnny Kim. He started his career as a Navy SEAL. He then decided to go to medical school because he didn't feel accomplished enough. And then after medical school, he enrolled in residency at Harvard, where during residency, he was selected to join NASA's astronaut program and is currently taking a hiatus from residency to train for the next moon mission. In the bottom left, you have Griffin Myers. Griffin was also a Harvard EM grad. He was very frustrated by the care he was providing in the emergency department. He saw a lot of potential to improve the care patients were getting outside of the ED. And he co-founded a company called Oak Street Health, along with two other people. And what Oak Street Health really did was went out into the Midwest, into rural communities and urban communities with minimal primary care access and targeted patients who were dual eligible. And those are patients who are eligible for both Medicare and Medicaid, who are often the ones who are caught in who end up in this ED because of poor access to primary care. And he was able to really impact the care so much that Oak Street became one of the biggest primary care companies and was actually recently acquired by CVS. In the middle, you have Dara Cass. She's also a former county grad. She is most famous for starting FemEM and has been a huge advocate for women in medicine. Most recently, she is currently a regional director for Region 2 of the Department of Health and Human Services. And then lastly, you have Raul Ruiz. He's an emergency medicine physician who practices in California and is now a sitting U.S. Representative representing California's 25th district. So to kind of close things out, I think talk through a little bit of the data. I think as I tried to explain, while the projections were useful, it gives us important information about where our specialty is going. Most of the predictions will not come true because we're going to address it and our specialty is going to change. In the end, the only constant in our specialty is going to be change, and the way we practice EM today is not going to be the same as how we practice EM in 10 or 20 years. And as a result, the main thing that we can all hope for is that we are part of the paradigm shift that occurs in EM and that we make the specialty be what we want it to be. I know there's a lot of uncertainty in our specialty right now, but I think that's where we thrive the most. And as long as we continue to organize the chaos, I think we'll all do just fine. These are my sources, and now open to any questions, or I'm open to debating this future as well.